Welcome, everyone. My name is Susan Vold. I'm a movement disorder nurse care coordinator and the deep brain stimulation program manager at the University of Minnesota M Health Fairview's neurology clinic. I've been in this role since 2012, and I've witnessed my patients living with a lot of issues and with their disease for nearly 9 years. So I've seen progression in a lot of them. As time has progressed, so has their illness, and that's the nature of a progressive neurodegenerative illness. Many of my patients are also dealing with the stresses of isolation due to the pandemic and the overall emotional climate of the United States right now. And so for some, it's pushing themselves and their families over the edge. Talking about these cognitive changes is key. It's the first step in decreasing fear, misinformation, misperception, and shame. It is when we don't talk about these things that our energies are spent walking a thin line with nothing to prevent us from going over that edge. So we need some tools in the toolbox. How do we handle this? I tell all my patients and their care partners that planning for a crisis when they're in the midst of a crisis is not a good idea. So talk about the changes that you are seeing, sensing, feeling. And I don't mean just the care partner. I'm asking the person with Parkinson's to talk about any changes. This takes courage to do. Get help to cope along the way. Cognitive changes don't happen suddenly. If they do, we want to look for a different cause other than Parkinson's disease. In order to understand what cognitive changes can occur in Parkinson's disease, we need to understand what cognition is in the first place. So cognition, according to Oxford Dictionary, encompasses a few things. These things right now. It's the mental action or process of acquiring knowledge and understanding through thought, experience, and the senses. So looking at this slide, you can see it has to do with attention, executive function, memory, language, visual spatial skills. This is all a part of that one word that we call cognition. So let's talk about the first thing, attention. That is that ability to focus on one thing while tuning out everything else. Now, this changes in Parkinson's disease. If a person has difficulty paying attention, it can be nearly impossible to follow a conversation or a plot in a movie. And this can contribute to feelings of anxiety in social situations, sometimes leading to the avoidance of those situations. A person with Parkinson's is in the middle of a conversation at a club event, and people are asking them a question and they just haven't kept up with the conversation, and so they're left not knowing what to say. So the question is, can you follow a conversation? Do you avoid social gatherings? Are you no longer interested in reading a book or watching a movie because you just can't follow the plot? Talk about this with your loved ones and your care team, especially. Executive function is exactly what it sounds like. It's what an executive would do who manages multiple departments, in a big company would do. This is the part of the brain that is particularly affected with Parkinson's. It's that frontal cortex, and it has to do with the decision making, multitasking, problem solving, organizing, planning. It's all the things that we do in our daily lives, and we just do them without thinking. However, in Parkinson's, that changes. So in Parkinson's, as the disease progresses, it's very hard to make decisions. If you're a care partner, the best thing to do is to offer two alternatives. Instead of saying, John, where should we go out for dinner tonight? Say, John, should we go to Pizza Hut or Applebee's? And then John will be able to make that decision a lot easier. So it can be overwhelming to have too many choices for a person with Parkinson's that the disease is progressing. Do you make poor decisions? That's another thing that happens in Parkinson's disease because of this executive functioning issue, like not wearing a seatbelt when you are driving or as a passenger, or spending more money than you should. Are you having more problems problem solving? Problem solving, like what should I make for dinner and I don't have anything in the refrigerator? That's a complicated task. And we don't necessarily think of it as complicated, but it has a lot of steps that need to be um, divided and conquered, actually. Is it harder to follow instructions or directions now? Do you need more time to accomplish and do the tasks that you have? You know, making coffee in the morning is a complex set of tasks that we have to think about and orchestrate and complete. Are you having more trouble paying bills on time, writing checks correctly, trouble multitasking, switching between tasks, like if you're writing down your bills and then you hear the TV over there, it's harder to get back to paying those bills. That multitasking can be very difficult. There's a saying that I've talked to my patients about, and it is, as Parkinson's progresses, it is very difficult to walk and chew gum at the same time. Walking is a complex series of steps that needs to be thought about. And if you're chewing gum, very difficult to pick up those feet all the way. Or when you are walking into the living room from the kitchen, doing that is difficult enough, but carrying something like a tray of food, absolutely very, very difficult to do. So it's very important to talk to people about what you are experiencing. We don't want you having falls, which are a key problem with this disease. Memory. There's different types of memory that we're referring to when we look at how memory changes in Parkinson's. So long-term memory, it has to do with memories that we keep for a number of days, or life experiences and skills. And like the slide shows, experiences like knowing how to ride a bike. That's long-term memory. Short-term memory has to do more with holding a little bit of information for a short period of time. Like if someone gives you the phone number 612-626-6688, and you say it over and over in your mind until you can get to a piece of paper to write that down. That's short-term memory. And then you've got working memory that uses the memories that you have to problem solve. So in this slide example, it's like doing math. Language. Language is also a part of cognition. And it's how we make ourselves understood, how we're able to empathize and understand another person. Is it harder to find the word you're thinking of? Word finding is a very big issue with Parkinson's cognition as the disease progresses. Visual spatial skills. This is an area too. In the retinal cells, there's dopamine receptors. And so, as you know, with Parkinson's, it has to do with dopamine. And so visual spatial skills are affected. We take this for granted. And as Dr. Jennifer Goldman states, these abilities tell us where things are around us in space. They give us a spatial map of our environment and involve our sense of direction. Visual spatial functions allow us to estimate distance and depth, use mental imagery, copy drawings, or construct objects or shapes. Examples can include things like giving someone directions to your house, tracing that route in your mind, avoiding obstacles that are sitting right in your pathway and putting together a puzzle. Those are all ways that this is impacted. So one care partner of mine actually said that when she had her husband empty the dishwasher, she would find plates and glasses and silverware all over different areas of the house. And this has to do with how you construct your environment. And so that can be affected with Parkinson's disease. There's also a decreased contrast sensitivity that occurs. And this is secondary to the loss of dopamine from those retinal cells. It can cause problems seeing contrast. So that can be an issue with falls and, like I mentioned, stepping over objects. Double vision is another problem, and it has to do with coordinating our eyes to move together, the muscles of our eyes. And when that is impaired, you can start to have double vision. It's usually intermittent, and it can respond to some anti-Parkinsonian medications, and it occurs most often when you're reading or in close vision, and in the evening when somebody is tired. So, what is the possibility of change with cognition in Parkinson's? Well, there are age-related changes, and then there is MCI, which stands for multiple cognition impairment, multiple domain cognitive impairment. And in the MCI category, there isn't any functional impairment. And what I mean by that is there's no problem with the person with MCI being able to take care of their activities of daily living, like bathing, eating, dressing, those types of things. There's no limitation that way, but MCI can stay the same, it can progress, or it can even get better day to day. What I often hear in Parkinson's patients is that their care partners may say, Sally is fine on Monday, and then on Tuesday she was very confused. I hear that a lot, sort of this up and down kind of thing. But as MCI progresses into dementia, this is a category where there are functional impairments, meaning that person with the dementia has a difficult time doing their activities of daily living, carrying out the tasks that are very important in our daily living. So that is what a progression would look like. And not everybody with Parkinson's will progress into this, but a large percentage. So sometimes people have said percentages of up to 50% of people with Parkinson's, as they have had their Parkinson's for a period of time, will progress into dementia. Let's talk about these things. This mild cognitive impairment. These are changes that are greater than expected for a person's age. So the things on the right in the boxes I want you to look at, and these are what you want to think about when you start having those issues of having trouble watching TV, not being able to read a book. These are things that you want to think about. Talk about it, for sure, talk about it. And then we want to look for some cause that's reversible, that's not has to do with Parkinson's disease. We want to look at those medications and the supplements. We want to see what could be impacting the cognition of the patient. We want to also see if there are sleep problems, depression and anxiety. And we want to be sure we treat those, because those things are treatable. And we want to get you the right referrals so that you can work with the people that can help reverse or keep things the same, or just help you in your daily life functioning. So if you're having trouble with cognition and you think that things have changed, you're going to be talking to your loved ones. You're going to talk and see your movement disorder specialist, and you're going to have a medication review. So there are a lot of medications that can impair thinking, a lot of medications. There's sedatives, there's narcotics, anticholinergic medications. Sedatives would be more like the benzodiazepines, clonazepam, um, Valium, that type of medication. Those can impact how you think. Narcotics, say you had hip surgery and you are given some Percocet, a pain medication can impact your thinking. And then anticholinergic medications are those medications that have like a drying effect on the system. And some of those medications are things that we use to treat urinary problems. Some medications we use to treat tremor, like Artane, which is trihexyphenidyl. That's an anticholinergic medication that can cause thinking problems. Benztropine, that can cause a problem as well. When you talk to your movement disorder specialist about changes that you are experiencing, that person is going to want to always know what your symptoms are in relation to when you take your Parkinson's pills. This tells us if your symptoms are more have to do with wearing off of the medication, or is this more of a cognitive problem? So if it's wearing off, we might decide to bring the doses closer together. We may decide to increase a dose. We might decide to add a medication to the cocktail, whatever it is. So that's why it's so important for you to be able to let us know what your symptoms are in relation to when you took your medication. Also, we want you to address any hearing or vision problems. So absolutely wear your hearing aids, wear your glasses when you need to, and care partners might need to help remind people with Parkinson's to do that. Dementia in Parkinson's. So a person with Parkinson's has a higher risk of developing dementia the longer they've had Parkinson's disease. If they have more of the rigid walking and balance problem, Parkinson's characteristics rather than tremor. If you have mild cognitive impairment, if you have hallucinations or delusions, absolutely have a higher risk of having dementia. So, as I mentioned, probably 50% of people with Parkinson's will have dementia after 10 years of working with this disease. Other predictors include older age, being a male, having the onset being bilateral instead of just the right side. We have both sides that are affected. REM behavioral sleep disorder is a predictor. Illusions, having orthostatic symptoms, feeling faint and falls, that type of thing. Depression, those give you a higher risk. So there is a key thing that we need to talk about, and it's not comfortable, but it's something we have to talk about, and that is driving. People with Parkinson's need to understand that Parkinson's is a progressive neurodegenerative illness, and thinking is going to become affected. Now, driving is a very, very complex skill. It requires, first of all, good movement, neck movement. It requires thinking ahead. It requires good vision, visual spatial skills, all these things that tend to deteriorate in Parkinson's. And so it's so important to have that conversation with family and with your movement disorder specialist about when is it time to give up the keys. Has there been a near miss recently? Maybe something to discuss with family is when you're willing to talk about it. Say, I'm going to be willing to talk about this maybe in a year or whatever. Or maybe family has been noticing things and they are concerned. It's not just about your independence. And your independence is so important. And driving, if you have to give it up, is definitely something to grieve. But we have to think about others and the safety of the public and the people that are in the car with us or just simply riding their bicycle on the street next to us. So driving is a key thing that needs to be discussed. Another thing is cooking. Sometimes when dementia has come about, people are forgetful of turning off the stove or burning themselves. So these are all safety issues, and safety has to come first. Independence and personal self-esteem is critically important, absolutely. But safety of yourself and others has to come first. So people and families talk about the possibility of dementia before your person with Parkinson's has this problem. They may not have the problem at all. 50% don't, but 50% do. So it's important to have that discussion about when is it time to give up the keys? How can we talk to you about our concerns when we feel that it's time to have these key conversations? The other thing, this is the time too, before dementia, when every single person, especially a person with Parkinson's disease, has a healthcare directive. Someone who will make key medical decisions when the person with Parkinson's is not able to make those decisions in a way that is realistically good for them. So having a healthcare directive notarized and given to your primary care specialist or your neurologist, this is very different than a power of attorney. I've heard patients say, I am so-and-so's power of attorney. You should be able to tell me all about his care. I'm sorry, I can't do that. Unless you are listed as authorized to discuss protected health information, or you have a healthcare directive that lists your name, I can't talk to you about so-and-so's care. Very important, families, to have this set up. All right, let's talk about what we can do and how we can make things a little bit better and easier to understand. So communication strategies are key for families. As I mentioned before, when you are given too many options, it's very difficult for the person with Parkinson's to make a decision. So as cognition decreases, and perhaps we're into now the dementia phase of the illness, don't ask open-ended questions. Instead, ask multiple choice questions like, do you want to go for a walk today? Yes or no? The reason multiple choice questions are better, or yes, no questions are better, is because that cognitive area of making, planning, decision making can become more and more difficult. Let the person with Parkinson's have a choice on what they're going to do that day. Before you speak with your person with Parkinson's, make sure that you have their attention and eye contact. So yelling at them from the kitchen and they're in the living room and you're having a conversation, that's not going to work when a person with Parkinson's has more developed MCI or dementia. too difficult. You need to gain their attention. Give the person with Parkinson's enough time to answer. So you've all heard about the motor symptom of bradykinesia, which is that slowness in movement. Well, there's slowness in thinking. It's called bradyphrenia. And the person with Parkinson's has the answer, but it's harder for them to find the file. Okay? So they've got the answer to your question, but they need time to access that file. So try. Very hard to do. And I had a care partner tell me that this is one of the things she has struggled with the most with her irritability and impatience. It's just easier if I do this, or it's just easier if I just take the reins. Yes, it is easier for you, but it's not easier for the person with Parkinson's. We have to have dignity and respect and allow time for them to answer. Be an active listener. Look for cues and meanings. So when you have that eye contact with your person with Parkinson's and you're talking with them, you're not going to see a lot of facial expression because that has to do with that masked faces that they get with the facial muscles. But you can watch for eye movement. You can look for body language, anything that might help you. And in fact, some people have a communication worked out with their partners where the person with Parkinson just gives like a hand motion. Yeah, I'm doing okay, or no, I'm not doing okay, or I'm above the line today, I'm below the line today, meaning their mood. So think about some of the signals that you can work out together. All right. So there is a slippery slope. In dementia, there's a possibility of starting to have illusion, hallucination, delusion. And it's not just during dementia. This can occur early in the disease as well. It can occur in the middle with MCI, but it does occur a lot more often when dementia is in play. So an illusion is where the person feels like there is a person or an intelligence that's in the room with them, but nobody is really there. Or the person with Parkinson's thinks they saw a small furry creature in their peripheral vision that just skittered by. Typically, it's a small furry creature like a cat or a squirrel. Sometimes words, when they're reading a book, might start looking like ants crawling on a page instead of words. Or a tree at the end of the driveway is looking like a group of people that are waving their hands, something like that. So a hallucination is more of having this perception and there's no stimulus, okay? So there's no tree at the end of the driveway that looks like something else. There aren't any words in the book turning into ants. So a hallucination is seeing or hearing or feeling or tasting things that are not there. And when we ask about hallucinations, we'll ask, does the person with Parkinson's have insight or do they not have insight? And insight refers to, do you know that it's not real? So some people might say, oh, yeah, I see a group of angels singing out the window on their bicycles. And you say, well, how do you know it's not real? Well, because I'm on the third floor. I know that they're not out there. So that's having insight. They know it's not real. And some medications, in particular Parkinson's disease medications, can cause hallucination. Amantadine is one of those medications that if I hear a patient saying that they hear a choir, auditory hallucinations are not very typical. More often than not, it's a visual hallucination, having to do with those visual spatial issues, I'm sure. But with amantadine, we've noticed how some people have auditory hallucinations. It's very interesting. So some of you may have heard of Lewy body dementia. And how do we know if something is Lewy body dementia or it's Parkinson's disease dementia? If it's Lewy body dementia, typically the visual hallucinations begin before the motor symptoms of the disease. And with Parkinson's disease dementia, the motor symptoms come first, and visual hallucinations may not occur for a year or more later. But a very important question to ask always when somebody says they have seen something is ask if it's scary. This can determine whether to treat or not to treat. If a person is seeing this cat that goes by and it doesn't bother them at all, there's really no cause to have to give another medication or to change medications if it's not bothering that person. But if it starts to become scary, that's no way to live. And then it's definitely time to treat. So a delusion, that's going even a step further. It is that strong belief about something that is not true, very paranoid in nature. Commonly in Parkinson's disease, the delusion that I hear about is spousal infidelity. The person with Parkinson's believes that their spouse is having an affair with someone, and they are convinced of this. And this can cause great problems, as you can imagine. Another delusion that I hear about sometimes is Capgras delusion. It's where you think somebody is an imposter. So the person with Parkinson's may have their wife or husband sitting next to them, but they believe that that person is an imposter, that the real wife or husband is somewhere else. So that's interesting. I also hear sometimes where the person with Parkinson's believes that somebody is stealing things or out to get them or hiding things, rearranging things in the house. So these are all red flags. Very important to talk about this with your provider. You can see here an example of what kind of, this is more of an illusion because it has a stimulus, and that stimulus is the trees on the hill. And the person with Parkinson's may have the hallucination that it's children playing up there on the hill. But these hallucinations and so forth are almost always visual. And they're usually small people, children, furry animals, and like I said, non-threatening in nature, and usually a side effect of the medication. They're more common late at night or early in the morning, and often when the person is falling asleep or waking up, very commonly. So it's just so important to treat these things. It can be life-changing, and one of the major reasons why care partners get to the point of burnout, and key reason why patients with Parkinson's go into care facilities. So treatment for hallucinations and delusions, to treat or not to treat. First thing first, we want to let's look at that word psychosis. So the first thing we want to look at is the Parkinson's disease medications, okay? Are they on amantadine? Are they on a dopamine agonist? Those are much more likely to cause these issues. If so, we may discontinue one, change up the medication in some way. The other thing we always want to look at is any systemic illness. Is there anything going on, with the patient as far as are they losing weight? Um, in the last month, have they lost all kinds of weight? Could they have cancer brewing? Some kind of systemic thing. Centrally acting medications are like those anticholinergics I mentioned. Um, the things that we use to help with urinary urgency frequency, like tolterodine or oxybutynin. Looking at tricyclic antidepressant medication, Benadryl, even. So we look at those centrally acting medications. The second thing, hepatic, renal, or metabolic dysfunction. Look at that. Any overdose of narcotic or benzo or even carbidopa levodopa, just kind of too much medication can cause hallucinations and delusions. Sensory deprivation. Are they using their hearing aids? Are they using their glasses? Is there an infection? Honestly, this is the first thing I think about when I get a call from a care partner. When there's a sudden increase in hallucinations, it's so often it's a urinary tract infection, and we don't see the symptoms of that as burning upon urination or fever or anything like that. But what we do see are falls or changes in cognition and hallucinations, that type of thing. So infection is absolutely something we look at. These are treatable things. The person is not having a hallucination because they're progressing in their Parkinson's disease. These are reasons that we can look at to treat and help. Hopefully those hallucinations, delusions, and cognitive impairment can get better. Pneumonia is another infection that we want to look at. And a structural lesion would be more like if the person has had a fall lately and hit their head, they could have a subdural hematoma in the brain, something like that, stroke. Any of those things can cause changes in mentation. Very, very important. At this point, absolutely do not have any firearms in your home. Get rid of the firearms. Make sure that you reassure your person with Parkinson's that the hallucination is a trick of the mind, and it's probably caused by medications. It's probably not them losing their mind, which is frightening beyond belief. So remind them that it's probably the medications. And then we have medications that help with treating hallucinations. Now, let's look at some of the things that we can do to lessen the impact of hallucinations or dementia for that fact. If you are taking care of someone with Parkinson's that has dementia and has progressed into this phase, you want to keep a very calm, quiet environment. You don't want political shows on TV. You don't want the news, which can be very upsetting. Even loud TV, violent programs. You can watch uplifting shows together. I Love Lucy. That's even before my time, but there are nostalgic kind of television shows that you can watch together. And have a lavender diffuser or freshener. Even that is helpful for the care partner to help keep you in that right frame of mind as well. Have a routine. Absolutely have a routine. Maybe have a whiteboard that you have listed what the activities are for that day. Again, make sure that your person with Parkinson's has their glasses and their hearing aids. And, in the late afternoon, it says here on the slide, lower the shades. It's late afternoon. You've probably heard the term sundowning. And that is when the light is changing in the environment. And because of the visual spatial problems. Shadows look like other things, and so make sure the environment is well lit and there aren't shadows in different areas of your home. So how do you deal with a delusion? So let's say your person is right then and there having a very difficult time and is paranoid and freaking out. What can you do? Well, one thing you can do is you can kind of test. You can tell the person with Parkinson's, tell the intruder to back off, or you can do it yourself. So, hey, get out of the house, back off. And you can actually ask that hallucination. You can ask the person with Parkinson's, where is the hallucination? What are you seeing? Not that you're agreeing with it, but you're asking them for clarification. What are you seeing? Where are they standing? And you could actually just say, hey, it's time to go now, and pretend you're ushering that hallucination out of the door. Sometimes that helps. We need to change the things we can because there's so much that we can't change. So I was just giving you some examples of reframing and redirecting. Don't argue. Don't argue with the person with Parkinson's. Ask them specifically what they are seeing. If they're having a delusion, don't buy into it, but don't agree with it either. Just ask non-intense probing questions to learn more about what the person believes and why. Remind them often that they are safe and secure and that you are on their side. Aim to turn the negative into a positive and cast a different light on the experience. So, for instance, I saw that guy before and he's really harmless. He's here to keep us safe. That's one way to look at it. Or, yeah, he first looked like a bad guy, but he's actually very friendly. And then move on to a different topic. You can direct the conversation away from something. Like, let's say the person with Parkinson's is seeing, let's say, a high school band out in the field playing music. You could say, oh, well, what kind of instrument did you play when you were in high school? And start redirecting the conversation to something else. So you're not concentrating on the hallucination. Those are some ideas to do together. So treatment for this dementia that we're talking about, we want to look at the treatable conditions. As I mentioned, we want to look at systemic illnesses, infections. We want to make sure they have their glasses and hearing aids and all those things that we talked about already. We probably will have to change the Parkinson's medications. We want to look at social stressors. Maybe there are certain things going on in their lives right now, like maybe you have to move out of your house. That's very stressful. Physical exercise needs to be done to expend some of this energy as well. So those are things that we need to do. And don't forget the person that's taking care of the patient. And that's you, caregivers. This is so very, very important. You need to get the right care at the right time. Make sure that you look at your resources. The APDA, the Parkinson's Foundation, Michael J. Fox websites. Those are all great things. Caregiving classes. Make sure that you're meeting with the social worker to talk about planning ahead. Get those documents in line that you're going to need. Make sure you take care of your own emotions. Talk to everybody and be open. And be sure that you honor yourself. Be sure you put the oxygen mask on yourself first, or you won't even be there for the person with Parkinson's. Love yourself and you guys are doing a great job. And I'm so glad that you were here today to see the presentation. Thank you.
Thank you so much, Susan. I think your talk really resonated with people. We've had a lot of questions come rolling in, so let's get started.
All right.
Our first question, someone has asked, can deep brain stimulation help improve cognition?
No. The answer is simply no. It's not meant to improve cognition at all. And in fact, any brain surgery can impair cognition. That's a risk.
Great, thank you for answering that. And someone else has asked, how or when can you set a baseline early on in order to judge changes in cognition later?
Well, when a person is diagnosed with Parkinson's, it's always a good idea to ask the provider for referrals for a neuropsychological evaluation, speech therapy, physical therapy, and occupational therapy right away, even when the symptoms aren't very bad, because this gives a very good baseline. But as time goes on, if there are questions or concerns, a shorter referral to an occupational therapist can help with doing a cognitive testing. Neuropsychological evaluation is a much more involved test that's 4 to 5 hours long, but the OT can pick up on things as time goes on. So OT referral.
Great, that's good to know. And someone else has asked, what are some good ways to keep track of symptom changes?
That's a great question. The APDA has a symptom tracker that is very helpful, and you can contact your local APDA or go online and see if you can download the PDF and actually print it out. But this is such a helpful tool to use when you're trying to get the most out of an appointment with your movement disorder provider. There's such a limited amount of time in that appointment, and you need to be able to pinpoint what's going on. And as I said in the presentation, knowing what your symptoms are in relation to when you take your pills is absolutely key. So these symptom trackers, some offices like our office has them for you. We can send them to you through MyChart or your healthcare website. And as mentioned before, you can get them through the APDA.
Yeah, absolutely. And I want to add that if anyone would like to keep track of their symptoms using their phone, APDA has a symptom tracker app available on the App Store for Apple and non-Apple Android phones.
Wonderful.
Yeah. So someone else has chimed in with, how can I get help untangling legal terms like healthcare directive and power of attorney?
Yes, well, social workers are the angels in this area. They can help in all stages. Also, the Agency for Aging, you can contact them as well. They have people that can help with that. But basically, it's very important to understand that power of attorney, that general phrase, is referring to the business financial aspects of a person. And so if so and so has power over attorney of Jim, they can handle the financial matters. That doesn't mean that they can even talk to me about the health matters of Jim. So the healthcare directive is that document that all of us should have filled out. And it's those the final wishes of what we would like to happen in our end time. And the important time to fill that out is when you can really think about it and make those choices with a sound mind and choose who is going to make those decisions for you when you cannot. The other document I mentioned is an authorization to discuss protected health information. Very important that when you go to the office to see your movement disorder team, ask to fill out that form. That way, if the caregiver needs to speak with me regarding what's going on with the person with Parkinson's, I can talk to them. If this isn't filled out, I cannot even admit that that person is a patient of mine. So those three things: authorization to discuss protected health information, a healthcare directive, and then the power of attorney is different.
Thank you. That was a fabulous explanation of those terms, and I think that's really helpful for everyone to know. Someone else has asked, how do you help a person who is in denial about their changes in cognitive symptoms?
Oh, that's really tough. When family members are afraid to bring up things like driving with the person, because driving is such an indicator of independence, and it's part of our personal dignity, that independence, to be able to drive where we want to. And there is this denial many times, and for good reason, not wanting to give up that independence. So oftentimes the care provider is asking us, the neurology clinic or the um, neurologist, to be the bad guy, and that's okay. Bring it up during one of your appointments with the movement disorder specialist, or give them a heads up before the appointment, and just give them a clue. Would you please bring up this issue? We can also do what's called a MOCA exam in the visit, where it's a short form that I would provide with the patient, and we would go through some things on the form, and it gives a very quick estimation of the cognitive ability at that moment in time. Anything under 26 is concerning. So that's one quick way to have that done.
Great, thank you. And someone else has asked, when is it time to look for a nursing home, and how far ahead should you plan for nursing home admission? Like 1 year or
Okay.
so on?
So nursing home admission is not for sure needed. It all depends on the individual with the Parkinson's disease. So the saying that if you've met one person with Parkinson's, you've met one person with Parkinson's, because everybody is so very unique. So, but if you start seeing signs of mild cognitive impairment, usually, I have to say, when it comes to the motor symptoms of Parkinson's, when patients have a very difficult time moving and that kind of thing, that doesn't put people into a nursing home situation usually. Care partners can usually handle that type of thing at home. It's when the behaviors begin due to cognitive impairment, um, the irritability that can happen with the patient, based upon their fear of the hallucinations or delusions that they're experiencing. So that can cause some behaviors, and that's what typically takes people to the nursing home point. So I would say that the time to start thinking about it is when a person has their faculties, and just talk to them openly about, here's Parkinson's disease, these are some of the risks that we're going to be facing in the future. I know that you love us, you love your family, and that you want us to be in good stead as this disease progresses. How should we handle this situation? And most people would not want to go into a care facility. There's very many different kinds of facilities. So it's not necessarily a nursing home. There are Parkinson's disease specialty homes where it's more like a group home setting. But the time to plan is not during a crisis. that is not the time to prepare. If you have a loved one who is already experiencing these hallucinations or dementia, it's time to talk to a social worker. And we have them at the clinic. Most clinics, I would think, have a social worker to talk to for advanced care planning.
Great. Susan, I really liked your idea that you shared about how to start that conversation with your loved one. So I think that's the hardest thing sometimes, is just knowing how to broach that. So thank you for giving us your thoughts on that. And someone else has asked, I've noticed that I've been having problems with my attention lately. Do you have tips for how to improve attention and focus?
Yes, in fact, I have problems with my attention too. And I think it's very, very important to stay physically active. And physical exercise is one of those things we stress in Parkinson's disease management. It's going to help your body, your mind, and your soul. So absolutely do your daily exercise. Try to get 15, 20 minutes of aerobic activity every day. Another thing you can do is to start learning a new language, start a hobby, use parts of your brain that need to have push-ups done, keep learning, very, very important. And get rest. If you're having trouble with your sleep, that will impact your cognition. So bring that up with your provider if you're having trouble with sleep.
Great. And I just want to let everyone know our next question will be our last question, but someone else has asked, is there anything I can do to prevent MCI from progressing into dementia, or to improve MCI in general?
That's hard to say, but as I mentioned earlier, the key exercise, keep moving, keep that heart pumping, and go to an occupational therapist, get a referral for that so you can learn ways to cope with any kind of lessening of attention and some of the executive functioning things. Do mind puzzles, do things to challenge your brain.
Great. Well, that's all the time we have, but on behalf of all of us, I want to thank you for sharing your presentation. We can all see your passion for this topic, and we're so grateful that you took the time to share this expertise with our Parkinson's community today. So thank you.
I am so grateful for the opportunity. Thank you.
Have a great rest of your day.
Thank you. Bye.
Okay.